I'm going to speak about the management of type 1 diabetes mellitus patients with budget-restricted resources. I have no conflict of interest for this speech. And to begin, I would like to share with you what happened with one of my patients, Adil. Adil was 25 years old. He has 6 years of diabetes mellitus, and he's on MPH and human rapid insulin. He has no complications, no comorbidities, and the last year, his A1C was between 7.5 to 8%. He has budget restriction, and he has insulin for free, and he could only afford 1 blood glucose a day maximum. And he came because he's willing to fast Ramadan. He told me last Ramadan, I fasted. He said without problems, but he had 5 hypos and he cannot say how many hyper. When you see that he's on human insulin, he's not well, his A1C is not well controlled, and he cannot afford a lot of strips, then in my mind, the only one and wise tip was to tell him not to fast. But we know through many studies that the fact is our diabetic patients, they want to fast and they fast. So what should we do with them? Especially the last Dar Global Survey shows that 20% of diabetic patients wanted to fast. In EPIDIAR study, it was 9%. And more of that, their A1C was not well controlled too, between 8.5%. Those who intend to fast were more than 70%, as you see here, more than in 21 with the EPIDIAR study. And those who fast effectively, they fast more than 15 days. In the Dar Global Survey, they were 80%. Some of them could also fast 30 days, so the whole Ramadan. 26% in the Dar survey, and almost 50% in the Darmena type 1 5 years ago. There is many differences between countries. For example, in Morocco and in Algeria, we have 1 to 4 diabetic, type 1 diabetic patients who fast Ramadan. And you see here in Malaysia, in Pakistan, they more than 75% of them. So all the doctors are going to deal with these patients, and complications that can arise during fasting, you know all of them. They are dangerous: hypo, hyper, ketoacidosis, and also dehydration, especially these last years when the fasting was in August, July, and it was very hot all over the world. Here you see those type 1 diabetic patients who fast, and you can see that they could have hypos, 40%, they could have hyper, 55%, and we didn't notice a lot of patients who require admission in the emergency room in the hospital. Only 6.8% had admission for hypo or hyper. So we know in these last years that we had a lot of tips who could help us to minimize the risk of hypoglycemia during fasting. Some studies have evaluated the use of specific insulin regimen to minimize the risk of hypoglycemia. For example, the use of rapid insulin analog compared to regular human insulin, or the last long-acting insulin analog are with less hypoglycemia. Additionally, the use of advanced technological feature had resulted in a significant reduction in hypoglycemia, especially with the continuous glucose monitoring and the insulin pump therapy, especially the low glucose suspend feature of insulin pump that has proven to be particularly useful to minimize the risk of hypos. My patient Adil, he doesn't have these facilities. He's on human insulin. He cannot do many blood glucose a day. So what could we do for him? The first thing is to emphasize that type 1 diabetes mellitus with reduced access to advanced medical care and also medical supervision, the fasting cannot be encouraged. And he was willing to fast Ramadan anyway. So the risk of hypos in type 1 diabetes like Adil that have reduced access to advanced medical care and also medical supervision because he was not followed before we met, it makes him in a very high risk. What should I do for him? I met him just before Ramadan. And he said, I'm coming here to ask for practical tips to safely fast during Ramadan. I am strongly motivated, but I have no resources. The doctor should, of course, say that the patient decision remains a personal choice and he must be respected. And then we should accompany the patient. First, we meet prior to Ramadan. 6-8 weeks before Ramadan. I met him 2 months before. Then we should do a pre-Ramadan clinical evaluation. Why? To stratify the risk and also to develop with him an individualized management plan. The risk stratification is very important because it will make us speak of the role of SMBG. Also, we are going to do education about when to break the fast, when to exercise, also fluids and meal planning, and medication adjustment during fasting. What is that risk stratification of people with type 1 before Ramadan? They must be aware of all potential risk during Ramadan. And people with type 1 diabetes mellitus who wish to fast during Ramadan, usually they are in high risk or very high risk before this risk stratification. With this new one, people need more flexible approach. And it's important to say that this is not to directly advise people with type 1 to fast. Of course, they are still at risk. And here you can see that the risk stratification is based on different factors, including pre-Ramadan glucose control, also duration of type 1, hypo risk, the level of hypo awareness, if they know when they have hypo or not, also the level of diabetes related education, if they could do self glucose monitoring, and also all these new technology. We cannot find any type 1 with low risk, but we can have some who could be on moderate risk, those type 1 who has basal bolus or insulin pump without complication and with a 0 in all this. So we may have some with moderate risk. For Adil, he's in high risk because he's a type 1. He has a duration of less than 10 years of type 1. He's also have hypos between 1 to 6 times a week. His A1C is 8%. He needs to do self-monitoring of blood glucose, but he cannot. He has no DKA, no chronic complication, of course not pregnant. He's not frail. He has no physical labor, and he has no negative or positive experience for last Ramadan. We are now going to fast less than 16 hours, and he's on basal bolus, even if it is not analog. So his risk is 8 and is in high risk. First, I'm going to ask him about the self-monitoring of blood glucose. He said he can do only one, but we should do more. He should do more. If he could do 7 times a day, it would be perfect. In the pre-dawn meal, morning, midday, mid-afternoon, pre-sunset meal, 2 hours after iftar, and of course, if he feels in hypo. He cannot. We should do something to increase the number of self-monitoring. Then we should explain to him when he should stop the fasting. When he has hypo, for example, blood glucose of less than 70 milligram per deciliter. Of course, when he's in hyper, more than 300 milligram. And if he has an acute illness or he has symptoms of hypos. And the last Ramadan, he stopped fasting when he had symptoms because he was not doing blood glucose monitoring. After that, we should speak about nutrition. He should divide the daily calories between suhoor and iftar, plus one snack, maybe 2 if necessary, because he's on NPH. We should include, as you know, low glycemic index, high fiber foods that release energy slowly before and after fasting. We should also have plenty of hydration, plenty of fruit, and he should keep hydrated between sunset and sunrise by drinking water and avoid caffeine and sweetened drinks. When to exercise, because they are always asking. We should say to maintain normal physical activity during Ramadan, and also the Taraweeh prayers. The Taraweeh prayers are very important because we are bowing, kneeling, rising, and this should be considered part of the daily exercise activity. Here, you can see all the recommendation for insulin dose adjustment and to say what we are going to do with Adil. I'm going to concentrate on NPH insulin and regular insulin. And here you see that the usual pre-Ramadan morning dose should be taken in the evening during Ramadan. And for the dose of the morning, 50% of the dose should be taken at the suhoor for the NPH. For regular insulin, we have 2 main meals. So those of the evening remain unchanged. And the suhoor dose should be 50% of the pre-Ramadan evening dose, and the dose of the afternoon should be skipped. Rapid-acting insulin should be 20 minutes before the meal. This is very important for better postprandial control. And also, we may have and require extra correction dose based on insulin sensitivity. Those who are in this basal bolus with regular insulin should do 7 times, as I said, 7 times glucose monitoring, or at least 2-3 staggered reading throughout the day. For type 1 who are on premix insulin, it is not recommended for type 1. We have some. If they are going to fast and they don't follow our advice, then we should ask them to have a fixed intake of carbohydrates at set time and to pay attention to the 2 peaks of activities, and we can have more than 3 daily blood glucose monitoring. What I did with Adil, because he has no physical activity except Taraweeh, we kept Taraweeh. He had 2 meals, iftar and suhoor, and he always take a snack after Taraweeh. He had a visit with our dietitian to fix the carbohydrate. We increased, because we were 2 months before Ramadan, the NPH dose and the human rapid insulin to 16 and 20. And these 16 in the morning and 20 units in the evening were, of course, during Ramadan, they were 16 units at iftar and 10 at suhoor. And we have 2 meals during Ramadan, so 8 units of rapid human insulin at iftar and 4 at suhoor, and of course, extra dose correction. He agreed to do 3 self-blood glucose monitoring a day, always pre-iftar, pre-suhoor, and another time in the day. And of course, if he feels hypo. And we had the next visit 1 week before Ramadan to set if everything was okay. And then the first week of Ramadan. In conclusion, we can say that patients with type 1 should be discouraged of fasting. Those who insist must be accompanied by their doctor. Of course, we had studies and we know that they are less hypos, but we cannot encourage all the diabetic patients to fast because we don't have studies with still now with this human insulin. We always have with this new technology, and it's still high risk. Don't forget, please, the post-Ramadan visit to see with them what happened. And of course, these type 1 diabetes, these type 1 with budget restriction need education. They need education, and they need even more education than the others because they are at high or very high risk, and they may have more hypos. Thank you very much.